anymore. I've got other people in the practice to do that. But I see an awful lot of conjunctivochalasis because a lot of my patients are quite elderly and they're coming in all the time. And I would never dream of telling them they have a dry eye. But I do think, going back to the other one again, we just have this penchant, I think, in our profession of quantifying things and listing things. And I'm not at all sure that we should be doing that. We should be diagnosing things. So, onward and upward. Blepharitis. All right, we all know about this. The comments I'd make about this one is a couple here. I think blepharitis sometimes can become almost as much of a throwaway expression as dry eye, in fact. And you say, oh yeah, okay, you've got bleph. But I do think a lot of it is because of poor lid tone and so on, and cicatrization and tylosis and so on as they get a bit older. So the one thing I always do, I tell my staff, I say, look, we want a gentle lid hygiene technique as opposed to vigorous, because you do get these patients, especially elderly patients, that say, oh, I've got bleph, I'm going to do this properly, and they make it worse because they're scrubbing the lids raw because they've been convinced that's the right thing to do. And if you've got a very poor lid tone and very poor distraction test and so on, giving a really good scrub is potentially just going to make the whole thing worse. So I think it's very important the patient know that yes, this is part of the problem, but the blepharitis might not be purely as we see in the corner there, a true posterior bleph there with meibomian gland dysfunction. It might just be because the lids are poor quality and they're not getting out there. Because the argument these days is, does it work anyway? We're supposed to be trying to get up to 35 degrees centigrade if we really want to treat bleph or posterior meibomian gland dysfunction. And that's the whole problem with the hot compresses and so on. So, there's a lot of talk now about bleph steam. I use that, but also there's the goggles that heat it up because they bring it up to 35 degrees, and then you've got more chance of liquefying the sebum and getting it out. There's also liposomal sprays now, the Actimist and so on. Now, I have not, historically, I wasn't a great believer in this. I always thought with blepharitis, look, if you've got poor lipid production, surely you should be trying to treat the problem, whereas sticking a liposomal spray on top is a band-aid. Now, I'm not convinced about that anymore, and we use it quite a lot. But I think you've got to be practical about it. You say, for certain people with poor lid tone in particular, and blepharitis that's intractable, then I think having this sort of stuff is really, really handy. It can help an awful lot. Because we have an awful lot of patients that, with the best will in the world, their lids are just too poorly structured now to ever get a good lipid production out of those lids. So I think supplementing the lipid with a liposomal spray is actually a very, very handy thing. But I don't use it as a sort of washed-out thing, just, yeah, you got bleph, put this in your eye, you'll be better. If they've really got bleph like the one at the top here, I'll be thinking, yeah, we've got to be vigorous with this, we've got to start massaging, we've got to start cleaning it up. But as an adjunct, I think the eye spray can be really, really good. The other thing that we can all do now, whether you're IP or not, I'm going to suggest to you, is systemic antibiotics. You can prescribe them via GP if you truly believe it's right. Now, I don't know whether we should go on too much about that, but I certainly prescribe fairly often doxycycline. You do about 100 milligrams a day for about 6 weeks, should really clear up really acute presentations. Not like the one in the corner, that just needs cleaning. But where it's really infected, you've got corneal involvement and so on, something like that, then I think that I'm quite happy to write to my doctor and say, look, we do need a course of this sort of stuff. So again, on the clinical management guidelines, it will again give you a nice 3-page option, and it will actually, or in this case 4-page, sorry, and it will tell you what might happen. So, if lid hygiene and topical antibiotic treatments fail, then you might do other things. And they mentioned doxycycline or oxytetracycline, some sort of tetracycline. What they don't do, though, is they don't give you any clue as to what sort of dosage. So yes, it gives you the theory, yes, it's all very nice, but they say possible management by ophthalmologists, oral drugs in the tetracycline family, but that's all they give you. Now, this is a web resource second to none. This is the top of my favourites list. This is e-medicines. Now, again, you have to register with this group, but you have to say you're an optometrist and you get in straight away. It's free. And then you're logged in and you can go into it at any time. You type in anything you like, blepharitis, red eye, allergic conjunctivitis, anything you like. And what it comes up with is, this is the opening page here, and it gives you basically an overview You can tip on the top there, you've got overview, presentation, differential diagnosis, workup, treatments, medications, and follow-up. And you can look up anything. Forget textbooks now. If you want to follow something up, or you want to look, or just say you made a diagnosis and you think, right, you're not quite sure what you want to do with this patient, say to them, look, I want to prep up a letter for you. I'll have it ready for you tomorrow. Send them off, and then get yourself into e-medicines, look the problem up, and then really clear it up in your own mind so you can really do a firm diagnosis or firm treatment. And it's an awesome resource. So you can get it via e-medicines directly. If you don't register with e-medicines, you can get it via the TRIP database. So you just go in there and type, but it's much, much easier. I used to do it via TRIP database, which is a good resource as well. But if you go into e-medicines directly and review, it's great. e-medicinesmedscape.com. So, back to ectropion again, I'm sorry. So you think, oh God, we're back to there again. What are we talking about? Now, this is now back to the clinical management guidelines. And what they also do though, and this is if you're going to start referring now, you've made the diagnosis, and why and when are you going to refer? And it tells you. It says management by the optometrist tells you what you might or might not choose to do, and then management by the ophthalmologist and what they may or may not want to do. And here we are, it does surgery. And what it does is, when is surgery indicated? And it's indicated when ocular surface exposure is too great, when there's chronic epiphora, recurrent bacterial conjunctivitis, or poor cosmesis. So again, the point is here, when you start to refer for this, you're actually referring on an intent to treat basis, rather than, oh gosh, yeah, poor lids, I'll just get this out of my chair. So, you know, I might say to the patient, yes, this is the problem, but it's not that bad yet. I think we can just manage it with lubricants perhaps, or something else. But at this stage again, you think, well, I actually think you need to be referred, and you'll write in and you'll say, I'm referring this patient because of a certain problem. It's poor cosmesis, or she's having, or he's having recurrent bacterial conjunctivitis, or whatever. So you're referring on an intent to treat basis rather than just anything else. And I think these things give you a wealth of information on what the patient may expect when they're going through. And you're not going to false positive refer them. You're not going to refer someone who's going to get bounced straight back to you because it doesn't fall into any treatment category. Now, this is my favourite. What about drug reactions? Now, we are taught certain things, aren't we? We all know that antihistamines cause dry eye. We know oral contraceptives cause dry eye. Anticholinergics cause dry eye. So, now, I want to question this somewhat. Well, it's all true, but I want to see how important it really is. Now, all of these things do. In theory, they have to. Most things cause dry eye because they have antimuscarinic effects. So even if they're not an antimuscarinic, like the tricyclic antidepressants have an antimuscarinic effect. Antihistamines have an antimuscarinic effect. And therefore, they must, in theory, stop tear production or reduce tear production. That's absolutely categorical. Pharmacologically, that's a fact. Diuretics, of course, have a different mechanism of action, but they have to do it as well. They dry you up, aren't they? But the thing is, I mean, how often have I ever caused an acute angular closure glaucoma, for instance, by putting antimuscarinic drops straight on the eye? I mean, I can count them in 25 years too, I think. So, you know, you've got to put this in perspective. I think we're taught a lot of stuff, and it becomes ingrained in our psyche that certain things are true. They're fundamental truths to us. But I'm not sure that the actual reality necessarily totally reflects how important they are in our minds. Now, if you type into this Myler's book, and you say, right, I'm just going to go in there, they have a whole list of things, a whole list of every side effect of every drug known to man. And if you type that in, or if you put it in, and you put in anticholinergics, they come up with these things: photophobia, pupil dilation, vision blurring. No mention of dry eye. If you put in antihistamines, they do have antimuscarinic effects. That's all it says. Blepharospasm and so on, vision blurring. And if you actually put in dry eye syndrome or dry eye conditions, it gives you a whole list of things. But not one there is an oral contraceptive or an antihistamine, or there's HRT in there. There's actually a drug in there for parasitic worms, but there ain't anything in there for antihistamines. If you then go into to the BNF, and you put in the Truzitol, which is for urge incontinence. Now this is how this book does miss things out. It will actually say, I mean, this is a really serious anti-muscarinic urge incontinence drug, and it does mention dry eyes. So milers isn't foolproof. But if you then go into the BNF and you say type in anti-muscarinic, it says side effects are now common with more older, right? They'll have impairment, anti-muscarinic effects such as urinary retention, dry mouth. They do mention dry mouth, blurred vision, but they don't mention dry eye. And if you go into e-medicine, electronic medicines compendiums, put in for cetirizine, which is a common one, very rare as a combination disorders, blurred vision, and ocular gyration, but again, no dry eye. So when you start looking at the information that's really there and really investigating it, I'm not sure that these drugs that we're taught so implicitly that have these effects are actually quite as bad as we think they are. Now, if we go on to oral contraceptives again, same principle. Type in oral contraceptives, and in milers what you get is retinal detachment. Now, I don't know how many of us have lost too much sleep over the last 25 years worrying about retinal detachments and oral contraceptives, but we've certainly been thinking a lot about dry eye. And I think it sort of puts things in perspective a little bit about how we really think about what we're being taught. And again, you put in dry eye, and certainly HRT is there every time. If you put in one, side effects, this is again BNF 61, there's all sorts of appalling side effects which you never want to read, put you off. But it says contact lenses may be irritable and visual disturbances. And again, a very common one, this is a common oral contraceptive, and this is in the SPC, the Summary of Product Characteristics out of the Electronic Medicines Compendium. And I put this in